I'm Charles Bankhead of MedPage Today, reporting from the American Association for Cancer Research meeting in Washington. A study reported here showed the feasibility of using biopsy-derived biomarkers to guide treatment of non-small cell lung cancer. Dr. Edward Kim of MD Anderson Cancer Center in Houston explained how adaptive randomization, an integral feature of the study, helped clinical investigators determine the best therapy for an individual patient.
The principle of it, without going into too many details, is to try and give patients who have distinct marker characteristics in their tumors a better probability of receiving a drug that may benefit them. And how that's done is, as the trial continues to enroll, every time a patient reaches an endpoint, in our trial it was 8-week disease control, that information, how they did at the endpoint, what their treatment was, how their biomarker group was, gets utilized into the statistical model real time. So the next patient who comes into the study who has a given marker group, and if, for instance, the prior patient had success, will have a higher chance of receiving that treatment, not just an equal randomization. And in our study, we had some things we learned, which was grouping biomarkers, but for the whole, we actually saw some benefit. And that's why this design is being adopted moving forward into other studies, larger studies, and having better biomarkers that we can utilize with better treatments.
The trial's primary endpoint was disease control at 8 weeks, which has been shown to correlate with outcomes in patients with non-small cell lung cancer.
If patients were able to achieve disease control at 8 weeks, their survival was 11.3 months. So clearly a nice surrogate, rather than waiting until progression, that we could establish with patients in this study. And they've done this retrospectively in the SWOG and other areas, that 8-week disease control seems to be a nice surrogate. If you did not achieve 8-week disease control, and both of these groups of patients had over 100 patients in them, the survival was 7.5 months. So clearly disparate. But the overall survival was 9 months, and the 1-year survival was 38% for the study.
Kim discussed the implications of the study for practicing oncologists.
I would hesitate to make any broad recommendations to clinicians based on our biomarker results or our treatment results. Remember, this was a phase 2 study, and I think any investigator who goes out there and trying to push phase 2 studies onto very knowledgeable clinical folks know that that's not the right thing to do. However, the message is about the tissue. They can influence what type of tissue is gathered, and that a patient, such as what we have up here, has that tissue, that in case we need to test biomarkers down the road, let's say we have a new one, people are talking about EML4 alpha, patients are coming in wanting to get that tested. Many of them don't have it. So are we going to re-biopsy all those folks? Again, that's the question. We can save a lot of time by getting good tissue up front. And we do that in lymphoma, we do it in sarcoma. In breast cancer, you would be appalled at a woman who had a breast cancer diagnosis of NOS, not otherwise specified. 15 to 20% of lung cancer patients have that diagnosis. We can't even tell what pathology it is, let alone biomarker.
From the American Association for Cancer Research meeting in Washington, I'm Charles Bankhead, MedPage Today.